Okay, good morning, everyone. Glad so many could join us. My name is Judy Biedenharn. I'm a member of the SDS MSA support group, and we just want to welcome everyone here to New Jersey. We have our board of directors that I would like to start out introducing. First of all, Vera James, the other co-president along with myself, is back there near the exit door. And Dr. Thomas Schleminski, who's now affiliated with the Medical College of Wisconsin. Did I get that order right?
Yep.
Okay. And Don Kraus, are you here? Okay, stand up, Don. Don is a pharmaceutical representative and has been on our board since about 2001 or 2? Earlier than that? 1998. So I was just a baby then, Don, sorry. But the other member of our board is Dr. David Robertson from Vanderbilt University, who unfortunately is not able to be here today. But the board of directors is here to help you, so if you have any questions at any time during the day, let us know. Otherwise, everybody will probably speak a little bit. And then we could not put this on without the help of physicians here in the area, experts in the field of MSA and neurological disorders. So Dr. Schleminski on our board is going to be presenting this morning. We have Dr. Lawrence Obi. He is a professor of neurology at Robert Wood Johnson Medical School. He is going to be our lead speaker this morning. And then we have a urologist, and Dr. Hari Tunaguntla. How bad did I do, Dr. T?
Very right.
Okay. So that's why we call him Dr. T, folks. But his name hopefully is spelt right on your handout. And then this afternoon's panel is Dr. Amy Coulter, and she just left University of Penn and going to start at Cooper Medical Center. Okay. And Joellen Fox, who is a lead therapist with the Dan Aaron Parkinson Center, and Marissa Palavac. Did I get it finally? So, I tell you, for a little Ohio girl, these names are tough. So, and they're going to be on the panel this afternoon. So after the morning session and after the afternoon session, there'll be a chance for questions and answers. So we hope everyone who came with a quest for knowledge will have that void filled today. So we can move right along. We're going to start out with our lead speaker, Dr. Lawrence Obi.
Thanks, Judy. I'm going to stand out here because that way I can keep you a little more awake with my body movements rather than relying on the brilliance of the content of my talk. It's really nice to have an MSA meeting here in North Jersey, where I grew up, and I work now in Central Jersey at Robert Wood Johnson Medical School, which is one of the 2 state medical schools here in New Jersey, one of the only 2 medical schools here in New Jersey, plus an osteopathic school. We're going to become part of Rutgers University in a few months, and we're looking forward to that. MSA is a topic that I have a particular interest in because my subspecialty in neurology, it's actually my subspecialty is movement disorders, which in practice mostly means Parkinson's disease because that's the most common movement disorder that generates patient referrals. Not the most common movement disorder overall, but it's the most common serious one that can cause disability. And within movement disorders, I have a particular interest in the atypical Parkinsonian disorders. And the most common of those is progressive supranuclear palsy, PSP, and MSA is a close second. And I'm very active with the Foundation for PSP, which is nicknamed Cure PSP. It's headquartered in Baltimore. I'm their Director of Research and Clinical Affairs. And but today the topic is MSA, And I'm just going to give you kind of a general overview that will serve as a bit of an introduction for the subsequent speakers. The overview will basically talk about the clinical features of the disease. That means the things that the patients experience and that the doctor can see right there. And let's get started. And in addition to the clinical features, I'm going to talk a little about the causes of MSA. We don't know what the cause of MSA is, but there are some theories. And the talk you'll get later from Dr. Kulcher on research in MSA will talk mostly about experimental treatments. I'm not going to talk about treatments. It would be nice if MSA had a catchy name. It's amazing how a catchy name like Lou Gehrig disease really does help fundraising and awareness and research. It's just incredible what a little public relations can do. All right, now MSA is, at the most simple level, you can start out by thinking of MSA as basically three main features: the Parkinsonian feature, the cerebellar, and the autonomic. And so this is how I explain this to my patients. Think of MSA as a triangle, and each person with MSA is going to be a point somewhere inside this triangle. And so, for example, some people may have almost all autonomic problems and only a little bit of Parkinsonian and cerebellar. Or somebody might be here, they have kind of equal amounts of Parkinsonian and autonomic and only very little cerebellar. Or someone might be in the middle, they'll have pretty much equal amounts of all three. And we now know that it's all one disease. It's just a matter of which part of the brain is affected. So these are the main parts of the brain affected by MSA. This is basically the basal ganglia. The basal ganglia are a set of clusters of brain cells. A ganglion in the brain, when we are speaking of the brain, a ganglion is just a cluster of brain cells as opposed to the wiring that connects those clusters. And the clusters are generally gray matter because the wiring has insulation on it that makes it white. So all this stuff that looks white, all in here, that has the insulation on it, and so that is not ganglia. The other things are ganglia. Of course, when we speak of the gray matter of the brain, we're usually talking about this layer on the outside, the cerebral cortex, but that's not very much involved with MSA, fortunately. So this is a section of the brain as if you were cutting like this. It's called a coronal section, like the corona of a saint in a medieval painting. Or you can cut the brain like this. It's called the axial section, cutting in this plane. And here you can see in the axial section, this part right in the middle that's kind of shaped like a flower is called the midbrain. And in the midbrain you see these two dark stripes, and they are called the substantia nigra, the black substance. And they're dark because of melanin, pretty much the same kind of melanin we have in our hair and our skin. And except it doesn't matter how much, if you could be dark-complected, dark-haired, blonde-haired, everybody starts out with about the same amount of melanin in their substantia nigra. And if you have any number of degenerative disorders, those brain cells that have the melanin, they die off. And the melanin is lost. It's reabsorbed by your system, and you just get kind of a smushy blur. And you get that in all of the Parkinsonian disorders: Parkinson's disease, MSA, PSP, and a handful of others. And this is how this all looks on an MRI scan. This is an MRI scan in the axial plane, just like that picture on the right that I showed you, except this is a little bit lower on the brainstem. This is called the pons, which is a lower level of the brainstem. And this is what it looks like normally, except for a little tiny stroke there that this person had. And this is what it looks like in somebody with MSA, where you can see the pons is kind of shrunken. And this part over here, it's the cerebellum, the balance part of the brain. That's kind of shrunken. You can see its layers here, because like a skinny cow. And this cross here, this is caused by scarring in the pons. when brain cells are damaged, scar tissue comes in, just like in your skin or anywhere else, as a way to repair damage. And because it happens in this cross, it looks like a hot cross bun. Looks like the frosting on a hot cross bun, and that's called the hot cross bun sign of MSA. You've probably heard of that. Now, the autonomic nervous system, I'm not going to spend much time in my talk talking about that. Dr. Chalimsky will go into much more detail on this. But this is just an overall view of the autonomic nervous system, which is a very important part of MSA. It also is affected a little bit in Parkinson's disease, and almost not at all in PSP. MSA is really the one where the autonomic nervous system is affected the most. And it affects things like the size of our pupils, the tear glands, saliva, heart rate, the muscles of the lungs, the action of the digestive tract and of the bladder and of the erection, and the other part, which is sympathetic, which uses a different set of nerves, kind of is the opposite. It's kind of the mirror image of the parasympathetic. And the two work together in a very complicated way. It's especially complicated when it comes to the bladder, because certain muscles of the bladder are sympathetic and some are parasympathetic, and Dr. Tunaguntlu will explain all that a little bit later. Now, MSA is not just the Parkinsonism, the slowness, the cerebellar, and the autonomic. It's also some other things called these are non-motor features, non-autonomic features. So depression is by far the most common of these. Insomnia, which can take many different forms of many different mechanisms. Sleepiness during the day, which of course could be a result of not sleeping at night. But in addition, you can just have sleepiness during the day, even if you'd sleep great at night. That's because the sleep regulation is affected in MSA and in Parkinson's and in PSP. Restless Leg Syndrome. You've probably seen this advertised on TV. Restless legs is a very, very common movement disorder, much more common than Parkinson's disease. It's just that for most people, it doesn't bother them that much, and they don't see a doctor for it. And besides, a lot of general practitioners, a lot of family practitioners know, primary care doctors, they're called now, know how to take care of restless leg syndrome, so I don't see them. But restless legs is another very common symptom in MSA, as it is in Parkinson's disease. Of course, most people with restless legs don't have a neurodegenerative disorder. Hallucinations and dementia can also occur in MSA, but the dementia is not nearly the issue that it is in PSP, and it's less also than it is in Parkinson's disease. Now, here is a diagram of the ages at which these diseases start and the milestones. MSA is shown at the bottom here. You notice that the left side of the gray bar is the average age at which symptoms first begin, the average age, and the whisker coming out is the size of the standard error. In other words, it's how much variation there is around the average. And of course, there's another whisker that would come out of the right side of this that they just don't show. And then the DX bar shows when the diagnosis is made on average. They don't show the whisker for that. And then the other things are shown here, the other milestones. Dysarthria or dysphagia is the D. Frequent falls, residential care towards the end of the course, urinary catheter needed, and becoming wheelchair dependent. Notice, MSA starts a little earlier than these other diseases. It starts generally in the on average, in the mid-50s, while Parkinson's is late 50s and PSP is early to mid-60s. Just averages. Notice also that the total disease course is similar in MSA and PSP. averages less than 10 years. While Parkinson's used to be this short before L-DOPA was invented back in the 1960s. It used to be the same. Now it's a lot longer. Now it averages maybe 15 years, something like that. Diagnostic clues. Diagnosing MSA may not be easy. One reason that it seems to be so rare in the population is that there aren't a lot of doctors who feel comfortable diagnosing it, especially when dysautonomia is not that important a feature. A lot of doctors have heard of the, quote, Shy-Drager syndrome, so they feel comfortable maybe misdiagnosing somebody with Parkinsonism and a lot of dysautonomia. They may feel comfortable calling that Shy-Drager syndrome, even though it may not actually be. But when it's just Parkinsonism and some cerebellar problem, then they feel kind of out to sea, and that patient may not get an accurate diagnosis of MSA as soon as they should. And so that tends to depress the apparent frequency of the disease in the population when someone comes along and measures it. So here are some diagnostic clues. Sorry about the technical term here, orofacial dystonia. That means a kind of an overaction of the facial muscles on a constant basis, where there's kind of a pinched look to the face or an excessively smiley look to the face at all times. This doesn't affect everybody with PSP. Pisa syndrome, kind of an unkind term. That's where somebody is sitting in a chair and they just kind of tend to lean to one side all day, and then you put them back up and they just lean to the side again. Sometimes there can be, the neck muscles will be bending also, and so the muscles on the side of the neck that are responsible will hypertrophy, they'll overdevelop. Disproportionate anticollis, again, complicated term for a simple thing. That's where, in a lot of people with PSP, their chin is on the chest all the time. Much more so than the generally forward flexed posture of Parkinson's disease. And the opposite of what a lot of people with PSP have, which is where they're quite upright or even flexed backwards a little bit, PSP. So this is a good diagnostic clue for the doctor in differentiating MSA from PSP, which can otherwise look very, very similar if there's not much dysautonomia. Jerky tremor. This is kind of a unique feature. That's where when a tremor is a very common part of most of these disorders, but when the tremor has a very rapid component to it, it looks jerky, myoclonic, we call it, that's something that MSA happens. MSA causes, and the other things don't. And disproportionate problems with speech. In MSA, it has this unique kind of a pinched quality to the speech. It's kind of sounds kind of like this when they're talking, as opposed to someone with PSP, where it's a much more there's more slurring, there's more explosive quality, and as opposed to Parkinson's, where the speech just is rapid and low volume. More non-motor, some purely non-motor things now. Abnormal ventilatory control. In other words, the breathing can be irregular. People can have noisy inhalations. It's called inspiratory stridor. That's where the inhalations can sound like this. And the breathing can be irregular, so that there are periods where the person seems to be short of breath and other periods where they seem not to be breathing. It could be very distressing for the family. That's what periods of apnea means, is periods where there seems not to be any breathing. And this can interfere with sleep, and it could be very uncomfortable. It could even interfere with oxygenation. Rapid eye movement behavioral disorder. This is something that can start years and years before the other symptoms of PSP. This is where, see, normally when we dream, the movement part of the brain gets disconnected from the dreaming part of the brain. But if you have MSA or Parkinson's disease, to a lesser extent PSP, that disconnection fails to take place during sleep. So you act out your dreams physically. And this can take lots of different forms. The form that's most noticeable is when there's some kind of violent action, when you're fighting somebody or trying to run away from something or having a vocal argument. And there can even be injury to whoever's sharing your bed. And then the person who has the problem doesn't remember this in the morning. So there can be some, marital discord, and the partner wants to go sleep in a different bed, and the patient takes this personally. This is easily treated, usually responds very well to a certain type of tranquilizer taken at bedtime, but it's something that often is not brought to the doctor's attention, because here you're going to see a doctor for your walking problem and your movement problem. Why bring up a problem with dreaming? What could that have to do? There's only a limited amount of time you have with the doctor. Let's not talk about irrelevant stuff. And yet, this is something where your quality of life can really be improved if you do bring it up. And it's something that the doctor should think about asking, because the doctor should realize that the patient is not necessarily going to bring it up. Okay, moving on. Cold hands and feet. This can be a really annoying thing. It can produce a constant, it's called cyanosis, kind of a purplish-blue discoloration of the parts of the body that are furthest from the heart, like the tip of the nose, tips of the fingers, tips of the toes. Raynaud's phenomenon is where, on exposure to cold, the hands go through, or tip of the nose, the feet can go through a series of colors. Forget the series, white, blue, red, and it can be painful. And it could be something very temporary. The exposure to cold can be very temporary, like putting your hand in the freezer to take out something. And finally, emotional incontinence. That's where there is uncontrolled laughter or crying in a situation that doesn't really justify that much laughter or crying. Now, helpful diagnostic clues for the doctor. These are negative clues. In other words, exclusion criteria. When one of these is present, MSA is unlikely. Onset before age 30. If that happens, you have to think about one of these hereditary conditions. There's a whole handful of them. Same family history of similar disorder. Hallucinations unrelated to medication. Those can happen in MSA rarely, but more likely it's a condition called dementia with Lewy bodies, which can cause Parkinsonism and early hallucinations before you've ever had any Parkinson medication. Of course, after you've been on Parkinson medication, those are a common cause of hallucinations, so then it's irrelevant. Some other explanation for the neurological symptoms: multiple strokes, multiple tiny little strokes in somebody with high blood pressure or diabetes. No one of these strokes might be enough to cause a problem, but in aggregate, over a period of many years, they can accumulate and cause a picture that looks a lot like MSA or Parkinson's disease or PSP. Always have to think about that. And they are preventable to an extent. Trauma can do it as well, and certain developmental abnormalities can do it also, but of course that would be, they would appear much earlier in life. Bad dementia that's out of proportion to the other features, very unusual with MSA. You have to think more about dementia with Lewy bodies or PSP, if that's present. Disproportionate difficulty with down gaze, with looking down. That's the hallmark of PSP. And focal cortical problems. That means problems with behavior or with thinking that can be traced to a specific part of the brain that neurologists know which part of the brain these things are. When you have all these things, you have to think more about a condition, a rare thing called cortico-basal degeneration. which can otherwise look a little like MSA. Aphasia means trouble with problems with words, with language, either sending or receiving. Alien limb means a problem where a limb just does things that it's not supposed to do kind of on its own. And spatial perception difficulty is where you just have trouble with things like finding your route on a map or getting dressed or other things that involve spatial skills. All right, so what's going on in the brain cells? Well, this is what's going on. These glial cytoplasmic inclusions, the glia are important brain cells. Many of our brain cells are glia, which means they don't have electrical activity. Their main function is to supply nutrients and protection to the cells that do have electrical activity. And these inclusions, these blobs, are in the cytoplasm, the fluid inside those glial cells, and this is what they look like here. I think I'm not going to go through this diagnostic criteria because this is kind of getting into a greater level of complexity than would be justified here. And even this slide is overly simplified. The diagnostic criteria, the official diagnostic criteria that neurologists are supposed to use in diagnosing MSA are really complicated. You can look them up. I can send them to you if you like, but I'm not going to get into it right now. Those blobs in the glial cytoplasmic inclusions are made of proteins. And with each of the neurodegenerative diseases, they all have their own kind of blobs. They're called aggregates. It's one kind in Alzheimer's. It's another kind in Parkinson's. It's another kind in PSP. In MSA, they're made mainly of this protein called alpha-synuclein. The normal function of alpha-synuclein, which may be irrelevant here, but the normal function is to help regulate synaptic activity. That means the process by which brain cells communicate with each other. But it's not that we lose synaptic activity in MSA. That's not what's causing the symptoms of the disease. The problem is that these blobs are forming, and the blobs are toxic. So they are in the glial cytoplasmic inclusions. The oligodendrocytes is one type of glial cell. That's where the GCIs occur. The aggregates in Parkinson's and dementia with Lewy bodies are also made of alpha-synuclein, but those are in the neurons, in the electrically active cells. Why is it that it's the glia in MSA and the neurons in Parkinson's? We don't know. And why does the alpha-synuclein aggregate in the first place? Well, it's probably that it folds the wrong way. And when proteins fold the wrong way, they tend to stick together. And they stick together into these small blobs at first of just maybe a dozen or 2 dozen protein molecules, and those are called oligomers, and those are the toxic ones. Those are the ones that do mischief in the cell. But they can't be seen through the microscope. They're too small still. And then the oligomers get together into those bigger blobs that can be seen through the microscope. And those blobs that can be seen through the microscope are probably not really that toxic themselves. They're just a way that the body's way of getting the real toxic blobs into one place and keeping them from doing as much damage as they would otherwise do. Now, there's a second protein in MSA. It's called P25 Alpha, slightly larger protein. It helps maintain its normal function is to help maintain the microtubules. The microtubules are an important part of our brain cells. They're used as kind of an internal monorail system to transport goodies along the length of brain cells. And the microtubules also serve as a skeleton, an internal skeleton, just like we have bones in our limbs that maintain the shape. Same thing with brain cells. They're made of microtubules. And the P25 alpha is found also in the blobs, these Lewy bodies, which are in Parkinson's disease. It interacts with alpha-synuclein. They accelerate the aggregation of alpha-synuclein. And your question now should be, well, okay, so what are these blobs of P25 alpha doing wrong? They seem to cause the myelin to break down. The myelin is the insulating material. Remember I said that the white matter of the brain has the insulation around the wiring? Well, what makes white matter white is the myelin, and that seems to be breaking down in MSA. Not as much as it does in the most famous white matter disease, which is multiple sclerosis. Very, very interesting theory in the last couple of years that may explain the cause of all of the neurodegenerative diseases is that they all may be prion diseases, prions. A prion is a general term for any protein that folds abnormally, like I said, alpha-synuclein folds in MSA, and then it not only folds abnormally, but it induces other normal molecules of the same protein to fold abnormally the same way, like in a chain reaction. And once these proteins are folded abnormally, they then aggregate, and meanwhile, the ones that are still floating around, they can just cause spread of the folding. And this is probably how these disorders spread through the brain. Now, we've known for maybe 30 years now, 40 years, that some diseases, some brain diseases definitely are caused by prions, like mad cow disease, for example. But now that same theory is being extended to these much more common diseases, which, unlike mad cow, are not transmitted from person to person, fortunately. This just shows you the chain reaction of the misfolding by the prions. And why is this prion theory so interesting and exciting? Because it opens up a whole raft of new possible targets for drugs, or for stem cells to work on, or for gene therapy to work on. It's a whole new pathway, and not only is it a new pathway, but it's a pathway that may be equally relevant to all of the neurodegenerative diseases. So that means if we can figure out the answer to the prions in MSA, it may be the solution also to Alzheimer's disease and Parkinson's disease, and vice versa, which is great news for people with MSA, because there's a lot more researchers working on these more common diseases like Alzheimer's and Parkinson's than on MSA, and yet the answer for Alzheimer's may turn out to be the answer for MSA. So in summary, MSA, like Parkinson's and many other neurodegenerative disorders, affects multiple areas of the brain and spinal cord, mainly basal ganglia, but many other areas as well. The three principal features of MSA are loss of balance plus muscle stiffness and slowness. We call that Parkinsonism. The old-fashioned term for that disease where Parkinsonism predominates is striatonigral degeneration. Second principal feature, cerebellar deficits, which means tremor and coordination. That used to be called sporadic olivopontocerebellar atrophy. And the third principal feature is dysautonomia. That used to be called Shy-Drager syndrome. Important additional features may be depression, breathing problems, cognitive difficulties, emotional incontinence, voice changes, and sleep problems. The hallmark of MSA are these glial cytoplasmic inclusions. They are made mainly of alpha-synuclein and P25 alpha. They're in the astrocytes, specifically the oligodendrocytes. And these proteins misfold, and they may induce the normally folded copies of the same protein to misfold in a chain reaction. Proteins that do that are called prions. And the prion hypothesis may provide us with a new way to slow or stop the progression of MSA. And if we can do that, then we'll have a breakthrough for all of the neurodegenerative diseases. Thank you very much.
Thank you so much, Dr. Golbe. Dr. Golbe is actually one of our host physicians this morning. Dr. Coulter will be the host for this afternoon, so we do thank you very much. You spoke in enough lay language for us to be able to understand, and enough medical language for people to know your expertise, and for that we do thank you.